I find it very sad and very distressing to think about a healthcare provider telling a person that they're not going to be able to engage in the activities that they love because of their asthma. Because when we think about asthma, we think about the fact that people with asthma should, with the proper care, be able to lead active healthy lives and do all the things that they love. It's a very rare scenario that a person would not be able to engage in their activities, whether it be vigorous physical activity because of their asthma. We're here today at a disparities conference because of the fact that there are, in fact, significant disparities in the burden of asthma in Maryland. There are certain populations that experience a disproportionate share of the asthma morbidity. And as we've already heard, the causes of these disparities are quite varied. It may be due to access to care being limited, whether that be primary care or specialty care. There may be lack of insurance coverage, which we hope that in the future will be not an issue for anyone with asthma. There also may be lack of access to education and awareness of asthma, whether it be awareness of the fact that they have asthma or awareness of the fact that their asthma can be controlled with proper medications. So the purpose of my talk today is to highlight certain Maryland data that illustrates the disparities within Maryland for asthma in order to help you all to be able to more successfully begin to develop interventions to address asthma. And I also hope to inspire you to, as you go through the day, to think about these statistics and consider how you can develop programs and interventions that target the unique factors and the unique needs of certain disparate populations. Now, the focus of my talk is going to be disparities as they relate to racial ethnic disparities, age-related disparities, as well as geographic disparities. And we've already heard Dr. Barbeau talk about the tremendous burden of asthma within Baltimore City, but there are other areas of the state that also share a disproportionate burden of asthma. We're going to specifically be looking at prevalence, emergency department visits, hospitalizations, as well as mortality. Now, when we look at prevalence as far as racial ethnic disparities, what we find is that in the adult population, the prevalence of asthma is actually quite similar between the white population and the black population. We also see statewide that the Hispanic population actually has a significantly lower prevalence of asthma. However, we do know that there are certain areas in Maryland where there are large pockets of Hispanic populations where that may in fact not necessarily be the case. When it comes to children, the statistics are quite different. We find that black children have 1.5 times more prevalence of asthma than white children, and that they have a statistically significantly greater chance of having been diagnosed with asthma at any time in their life, as well as to indicate that they are currently suffering with asthma. This chart basically just shows the same statistics as it compares to the United States population. And what we find, again, is the similarity in the prevalence across the adult population and the wide disparity in the childhood population, specifically for African American children. When we look at emergency department visits, hospitalizations, and mortality, we find that despite a similar prevalence in the white population and black population of adults, we find that adults are 4.5 times more likely to have an emergency department visit due to asthma, 3 times more likely to be hospitalized due to asthma, and over twice the likelihood of dying from asthma. The increased risk for ED visits, hospitalizations, and mortality cannot be explained because of an increase in their prevalence. And this slide is just meant to show you that despite a similar prevalence, we see a great discrepancy in these indicators of emergency department visits, hospitalizations, as well as mortality. When we look at gender differences, we find that female adults are more likely to have asthma than male adults. We also see that adult females have more hospitalizations and more mortality, despite the fact that the prevalence and emergency department visits are only slightly higher than the general population. Now, we've already heard about issues related to socioeconomics as they relate to Baltimore City, but what we find across the state is that there is a significant discrepancy in the prevalence of asthma by socioeconomic status. And when we look at prevalence by income, you can see that in the two lowest income strata, we see a significantly higher prevalence of asthma as compared to the higher incomes. And what's also interesting is that when you look at $25,000 a year to all the way up to more than $75,000 a year, the prevalence, while it may seem a little bit greater for the $25,000, it's not statistically significant. So you can see that these much lower income populations are significantly more likely to have asthma. Now, when we look at the age population, ages related to asthma, hospitalizations, and ED visits, we find that children who are less than 5 years of age have a disproportionate number of hospitalization and emergency department visits compared to the older age groups. And children less than 5 years of age have the highest rate of emergency department visits and hospitalization, as well as children who are less than 5 years of age not having significantly higher prevalence, or having, children less than 2 years of age don't have a significantly higher prevalence, but they do have a significantly higher amount of hospitalizations and ED visits. When we look at that graphically, we can see that children in the 0 to 4 age group have significantly higher ED visits, and we see that progressively decreasing as you go up in age. One of the things that, as you go through the day and you think about how to reach that 0 to 4 population, the issue of how to reach children in child care settings becomes an important factor in addressing this age group. When we look at hospitalizations, the trend is very similar, although with the elderly adults, those over the age of 65, we see again a significant increase in the hospitalizations by age. But again, 0 to 4 population is significantly impacted as far as hospitalizations. Now, geographically, as we already mentioned, that Baltimore City has some of the highest rates of asthma, not only in Maryland, but also nationally, with Baltimore City hospitalization rates also being over twice the rate for the entire state of Maryland. We also see that in Allegheny County and Cecil County, as well as in Dorchester County, we also see higher rates of hospitalizations. It's also unclear whether or not some of those increased rates are related to access to care issues in some of the more rural areas of the state, or whether there might be environmental factors that are unique to the rural population. And this is just a map of Maryland that shows some of the disparities in hospitalizations. And you can see that Baltimore City stands out in having the highest hospitalization rate. And then as you look to the areas in the darker green area, those are the ones with the lower hospitalization rates. It's unclear, again, why Allegheny, Cecil, and Dorchester County seem to have higher rates. And again, it may be related to the fact that they're rural counties, but there are other rural counties that have lower hospitalization rates, and so it may be related to access to care issues. I don't have that data off the top of my head, but we can certainly look at that. What we do have is overall data about smoking, and we do find that there is an unusually high number of persons with asthma who actually are also smokers. And so it is unclear whether or not there's a geographic distribution in that. I have not really looked at that data, so I don't know if there's a higher percentage of smokers in those 3 counties. So when we think about addressing asthma disparities, we really need to think about focusing on groups with the highest prevalence,
namely African American children, adult women, and individuals in lower income levels, as well as groups who have poor asthma outcomes, specifically, again, Black adults and children less than 5 years of age. Interventions should look at the system of care for these populations. As we already mentioned, access to care, specialty care, as well as the quality of care is very important. And then we also need to look at interventions that address caregivers and healthcare providers who serve these disparate populations. And so as you go through the day today and you think about what's being presented in terms of how to reach these difficult to reach populations, think about the specific subpopulations, minority populations, rural populations, very young children, and how you can apply the concepts that you hear today to these disparate populations. And Susan, I don't know if we have time for any other questions. I think we're behind time. Are we? Okay. So thank you very much, and I apologize for the technology glitches here.